Well, I'd like to welcome everyone tonight. We're going to get started on tonight's lung cancer webinar. So thank you all for joining us. Over the next 45 minutes, our physician panel will cover lung cancer risk factors, diagnosis, and management. And in a minute, I will introduce our speakers. But before that, just a couple of quick housekeeping things I want to cover. First of all, we are recording tonight's session to make it available for those who weren't able to attend, and also to provide the link to any of you attending that would like a link after the presentation. And then secondly, throughout the presentation, you're welcome, and we encourage you to drop questions into the chat. And as they arise, our speakers will field those throughout the presentation. So again, feel free to drop those in the chat at any time. So now I'd like to introduce you to our physician panel, who brings a coordinated multidisciplinary approach to cancer care at PeaceHealth Southwest. Joining us tonight are pulmonologist Dr. Bhanu Patibandla, who will serve as our moderator, and he is joined by Dr. Svetlana Kotova, a thoracic surgeon, Dr. Nina Dhami, a radiation oncologist, Dr. Ali Dadla, a medical oncologist, and Dr. Patricia Wooden, who is a primary care physician. So now I will turn it over to Dr. Patibandla for tonight's presentation. Thank you.
Wonderful. Thank you, Deborah, for the introduction. And thank you, everyone, for taking the time today and joining us and for being a part of raising awareness on lung cancer. November is Lung Cancer Awareness Month. So the main purpose of this webinar is to provide you all with information on lung cancer so that you're all aware about the risk factors for lung cancer, how we can lower that risk, and what are the different types of lung cancer and the various treatment options available. It is very exciting to see the options for detecting, diagnosing, and treating lung cancer are steadily growing over the last few years. And with that, people are now living longer with lung cancer compared to that a decade ago. In addition to the improved diagnostics and treatment options, collaborative multidisciplinary care plays a key role in improving the lung cancer outcomes. Because, as you will notice in the session today, lung cancer management involves multiple specialties and teams. I'm joined here, as you all can see, by some of my wonderful colleagues from various specialties at PeaceHealth that play a key role in managing and taking care of lung cancer patients in our communities. You will hear from them all on lung cancer management with their unique expertise and backgrounds. But first, I would share a few slides just to provide a vantage point for the discussion that follows with my colleagues later. Again, as Deborah mentioned, we want this to be fun and interactive. So please don't hesitate to drop any questions you may have on lung cancer. We'll take them as we go during the session or address it at the very end. So without any further ado, let's proceed. Lung cancer is the leading cause of cancer deaths in the United States. Every year, lung cancer kills more people than breast, prostate, and colon cancers combined. On an average, every 4 minutes, someone in the US will die of lung cancer. Lung cancer is not only the cancer associated with highest mortality, it is also one of the most common cancers. In women, it is the second most common cancer next to the breast cancer. And in men, it is the second common cancer next to the prostate cancer. It is estimated that in the United States, this year alone, there are more than 200,000 lung cancer cases. On an average, again, every 2.5 minutes, someone in the United States is diagnosed with a lung cancer. As it is well known, cigarette smoking is the leading risk factor for lung cancer. About 80% of the lung cancer cases are attributable to cigarette smoking. I must emphasize here, though, that cigarette smoking is not the only risk factor for lung cancer. There is a common misconception that lung cancer is a smoker's disease. In fact, about 20% of the lung cancer cases are diagnosed in someone who have never touched a cigarette. And the other risk factors for lung cancer include exposure to radon gas. Radon gas is a naturally occurring radioactive gas that is released from the soil containing granite rock. We can't really smell it, we can't taste it, we can't see it. So there are no specific signs suggesting that one may be exposed to radon gas. If you are concerned about radon gas, the best way to mitigate the risk is to have your homes inspected for the radon gas. And if you're living residence is identified to have high radon levels, there are ways to mitigate the exposure. And more information on that can be found on the website that's listed here. Other risk factors for lung cancer include exposure to asbestos and certain metals like nickel and silica. Air pollution is also associated with increased risk for lung cancer. It may not be that of a concern here, but still a major risk factor in developing countries. Certain lung conditions like COPD and fibrosis can also increase the risk of lung cancer. If you have a family history of lung cancer, that also increases your risk. It is common to think that lung cancer is just one disease, but in reality, there are many different types of lung cancer. Broadly, there are two different types, non-small cell and small cell lung cancer. Again, within non-small cell, there are three different types of cancers, adenocarcinoma, squamous cell carcinoma, and large cell carcinoma. Basically, this is based on the type of lung cell from where the cancer originated. In addition to the non-small cell and small cell lung cancers, there are also less common lung cancers such as mesothelioma and carcinoid tumor. Mesothelioma is a cancer involving the lining of the lung, and it is exclusively associated with exposure to asbestos. So when someone is diagnosed with lung cancer, it is very important to know the type of lung cancer because the type of lung cancer influences the treatment. In addition to knowing the type of lung cancer, it is also very important to understand the stage of lung cancer because staging determines the treatment, and you'll hear more about it from my colleagues in a little while. As we discussed, non-small cell lung cancer is the most common type of lung cancer. So I would like to give you all a brief overview on how the non-small cell lung cancer is staged. As we can see here, there are 4 stages, stage 1 to stage 4. The higher the stage, the more advanced the cancer is, and the farther it has spread. As the pictures here are illustrating, if the cancer has spread to other body parts than the lung, for example, like liver, bones, or brain, it is considered stage 4. If the cancer has spread to the lymph nodes in the chest, which are often the first sites where the lung cancer spreads to, it can be considered as stage 2 or stage 3, depending upon the site of the location of the lymph nodes. If the cancer is just localized to the lung, and if it is less than 4 centimeters, it is considered stage 4. So it is important to understand the stage of lung cancer at the time of diagnosis. And your doctor may order tests such as PET scan or bronchoscopy to determine the stage of lung cancer before designing a treatment for you. One of the main reasons why lung cancer is associated with such a high mortality is because oftentimes it is diagnosed late. 2 in 3 lung cancers are diagnosed at advanced stages when the treatment options are limited to offer curative treatments. One of the best ways to improve the lung cancer outcomes is to diagnose it early, and that can be achieved through lung cancer screening. Studies have repeatedly shown that lung cancer screening improves mortality by almost 20%. And the screening is done using low-dose CT scan, and the lung cancer screening is recommended for certain high-risk individuals based upon the age and their smoking history. If you're someone who is between the ages of 50 and 80, and if you have smoked for more than 20 pack years, if you're still smoking, or if you have quit smoking in the last 15 years, lung cancer screening is recommended for you. And again, lung cancer screening is done using low-dose CT scans, and it is recommended to be done on an annual basis. So with that said, I would like to pause here and see if we have any questions from the audience.
We don't have any questions yet at this time.
Okay, thank you, Deborah. And now I would like to invite Dr. Wooden to share her thoughts on lung cancer management in general and lung cancer screening in particular, especially with her background in family medicine. Dr. Wooden?
Thank you. I think this is really a very interesting topic. One of the major challenges that we run up against in primary care is really defining that pack year history. People have sometimes very complex smoking histories. They smoked a pack a day for several years and then quit for a while and then picked it up again. And so I'm curious how we help patients best navigate that? How do we help them calculate that pack year so that they know if they're eligible for screening?
Yeah, that's a great question. Dr. Kotova, would you like to take the question?
Sure. Yes, sure. And thank you for organizing this webinar. The math is pretty simple, and it's multiplying the number of packs per day person smoked times that number of years. So, but it can get complex, as in someone who has smoked maybe less at the beginning, more in the middle, and then less now, or maybe had intermittent points where they stopped altogether. So, but it is basically just adding each of these intervals. So if you smoke for 1 pack a day for about 10 years, and then you stopped for 5 years, and then you resumed and kind of went back to it for 3 years at half a pack a day, then it ends up being 10 times 1 times 10 plus, you know, you don't add anything for when you don't smoke, plus that half a pack times 3, which ends up being about, you know, 11.5 pack years. So it's not difficult, but it's keeping track of when you did and how much you did.
Yeah, and I think the other big question that I come across with patients as I'm counseling them is they really are concerned about, so I do the screening and something comes up, and then what happens? What do I do if there's an abnormality that's found during screening?
Yeah, I think that's a very good question. One thing is, more often than not, the screening exams don't show anything abnormal or concerning. And generally, the next step is we recommend getting a CT scan another year from there to continue to screen for lung cancer. And sometimes lung cancer screening exams show abnormal small areas in the lung, which are often called lung nodules or a spot in the lung. And the number one reason why we care about the lung nodules is because some of them could be cancer. But it's also very important to note that more than 90% of the time, they're not cancerous. And when I see patients with the lung nodules in my clinic, I often tell them, hey, there's a long list of things why you may have lung nodules. But I can say from the patient's perspective, the only thing that they care about is this cancer or not? That's all they care about. And for us to determine which of these nodules could be cancer or could become cancer, it involves a careful and systematic approach. We look into a few things from the patient side: how old they are, how much they have smoked, what kind of work they have done, anybody in the family have lung cancer, all these things. In addition to that, we also review their CT scans carefully because some of the characteristics of the nodules itself carry higher risk for cancer than some other characteristics. So we've taken all this information to risk stratify which of these nodules could be cancer. We actually have risk calculators wherein we plug in all this information, and that gives us a number. For example, something like, hey, this nodule has a 20% probability that this could be cancer, while this nodule has like 80% probability that this could be cancer. So we have ways to kind of risk stratify this nodule. The level of suspicion that we get from it, and also from the patient's preferences, the next steps are recommended. If we think that the probability of cancer is low, sometimes we say, hey, get a follow-up scan in 3 months or 6 months. Because we think that there's something there, but we're not really concerned that this is cancer, but it is important to keep an eye. So we call that watchful waiting. In some cases where we see a nodule and think that this is high likely to be a cancer, the next steps can be a biopsy or a PET scan to get more information about what that nodule could be. And sometimes we see a nodule and it looks like a cancer, it screams like a cancer, then we'll be like, okay, I think unless proven otherwise, this is behaving like a cancer, I think we should proceed with either biopsy or surgery. So very different options depending upon the probability of nodule being cancer and also patient preferences. Would anybody like to add anything to that?
I would say that probably a referral to a kind of comprehensive do comprehensive group, such as we have a pulmonary nodule and screening program where these things can be figured out and probably investigated in a little bit more kind of structured and probably more expedited manner would probably be maybe the best and most efficient way.
Yeah, I completely agree with that because as we have discussed, there are quite a few possibilities and potential next steps. And I think having a structured approach and a streamlined pathway would greatly help the patients navigate through this process. Okay, fantastic. Any more questions or thoughts from you, Dr. Wooden? Wonderful. Thank you. As we have touched upon the topic of surgery, I would like to take this as a segue to ask Dr. Kotova a few questions about surgery. Dr. K, thank you for joining. And, Dr. K is the head of the thoracic surgery at PeaceHealth. She is extremely passionate about lung cancer, and she is very focused on minimally invasive and robotic surgery. So a few questions to you, Dr. K. When is surgery an option for lung cancer patients?
Surgery is typically an option. Probably the easiest method to answer is it's best option for patients who have early stage lung cancer. Basically, it's where it's located to just one, localized to just one location, so that surgically we can go and remove that portion of the lung with a tumor in it. And that's typically stage 1 and stage 2. As if the cancer has progressed to multiple locations, either it's within the lymph nodes or it's within other areas of the body, and surgery is not the best starting place. Mostly because we just can go and take out all of that, all the cancer cells. So that's where surgery can play a role with more advanced lung cancer patients. But it has a more limited role, and it has to be really put in perspective of other treatment options such as chemotherapy or immunotherapy or radiation. This is where, again, kind of comprehensive approach with multiple other specialty physicians such as Dr. Dhami and Dr. Dadla and yourself, where we make the decision what will be the best stepwise approach and where surgery fits in, whether it's the beginning or the end or the middle portion.
Fantastic. So the earlier stages, surgery is considered more often than the later stages.
In fact, it is the best and preferred treatment option for patients who are otherwise fit to undergo surgery and undergo anesthesia, and otherwise will benefit from having the surgery.
Fantastic. And what are the different types of lung surgeries, Dr. K? Would you expand on that?
Absolutely. The typical surgical approach is to remove the part of the lung within which the tumor is located. And even though the pictures do not demonstrate, it only kind of shows that there is a left and the right lung. The lung is typically divided into more portions. So on the right side, we have 3 portions to the lung, and on the left, 2 portions of the lung. And a typical approach is if the tumor is sitting in the upper part of the lung, and we're going to go and remove the upper portion of that lung, upper lobe, or if it's in the lower lobe, then it's going to come out, the lower lobe will come out. However, in more recent years, probably in the last 5 to 10 years, as we started detecting smaller and smaller tumors, which can be maybe as small as a quarter of an inch, taking out that much of the lung becomes more difficult. So we've designed and kind of adjusted the surgical amount of surgical resection to address this a little bit better. So now we can go and perform smaller resections called sublobar resections in patients in whom it's appropriate and the tumors are located and they're small enough to achieve the resection without compromise of the overall results of the cancer surgery. And that's became more possible with more minimally invasive approaches that were also kind of developed over the past 10 years.
Fantastic. So now with the advanced technologies and the ability to identify early stage lung cancer with screening, there is even opportunities to resect smaller sections of the lung than a lobe.
Exactly, and that's the whole goal, that we can achieve the same result as with a larger operation, but with removing less lungs, so that the person's recovery is much faster, and they preserve a lot more lung parenchyma without the limitations that will be reflected in their breathing and their kind of exercise capacity.
Fantastic, fantastic. So the goal is maximizing or effective resection for maximizing the lung cancer outcomes, while also balancing the approach to preserve the lung function and quality of life after the surgery.
Yes.
Fantastic.
Very good summary.
Fantastic. So what are some of the things that you would look into, Dr. K, when you're offering surgery to the patients?
Couple things. So since this is a person in whom I'm going to be taking out in part of the lung, I typically pay attention to what their breathing capacity is. And do they have enough lung capacity that if I were to remove some of the lung, then they still have enough to breathe without being very limited and going on oxygen at the end of surgery. Because if I do this and the person is not able to really breathe, and all they do just take 2 steps and they're out of breath, that's really not going to facilitate any quality of life. So one thing I pay attention to what the lung capacity is. And the second, probably the most important thing, is what the overall strength and overall health of the person is. So someone who's strong and is very active, even if they're maybe advanced stage, something like 75, 76, or even 80 years old, but they're otherwise strong, they will very likely benefit from surgery versus someone who may be really frail and debilitated. So those are probably my most, the 2 things that really help me determine whether surgery will be beneficial and should be an option for a given patient. Fantastic.
Would smoking also factor into your decision making, or would you? How do you approach if someone is smoking around the time of surgery, Dr. K?
Oh my God, I hate smoking, because if people weren't smoking, we wouldn't have that much cancer. But yes, I do believe that stopping smoking before surgery is going to be of huge benefit, and it's not just for lung surgery. It's stopping smoking is going to have positive effects on pretty much any other health characteristics. It's it's going to help with your blood pressure. It's going to help with a lot of other things. So I do recommend that patients stop smoking. It does not change how I do surgery. It doesn't change any technical aspects of surgery, but it does make your recovery, if you still smoke up until the time of lung surgery, a lot more challenging and a lot more difficult.
So continuing to smoke affects their recovery from the surgery and the outcomes.
Yeah, it's. I think it affects your ability to recover, and you're more likely to have complications. You're more likely to have things that will lead you back to the hospital, potentially getting readmitted and treated for pneumonia. Which is probably one of the worst things that can happen after you have lung surgery.
Yeah, and I think we have studies showing repeatedly that in people who continue to smoke after the lung cancer diagnosis, the way they respond to the treatment is inferior or lower compared to those who quit smoking. Oftentimes, when we see patients who are diagnosed with lung cancer who are still smoking, they feel discouraged, and they came to they're at that point feeling like, okay, what's the point? We already got the lung cancer. How does it matter now if I smoke cigarettes? It is never too late to quit cigarettes, and you would still have benefits with quitting cigarette smoking. Dr. Dadla and Dr. Dhami, would you agree with that? Do you have anything else to add to that?
Absolutely. Additionally, with smoking, it does increase a risk of complications with treatment too, such as pneumonitis, which is inflammation of the lung related to, after radiation or even immunotherapy. Patients do recover better and quicker when they quit smoking. So it's never too late to quit.
Dr. Dadla, I think you're on mute.
I agree. It's never too late to quit. Sorry about that. Yeah, it's always helpful, and it does significantly improve survival.
Yeah. So, quitting cigarette smoking can sometimes be challenging, especially if you're smoking for years, right? Because it is a form of addiction, and you don't need to do it alone. Now we have proven techniques and multiple medications to help you quit cigarette smoking. So if you're someone or if you know someone who is smoking and struggling with that, uh, please seek help. Please talk to your primary care or anyone in your healthcare team to know the options to help you quit cigarette smoking. And I think, Dr. K, one last question that I have is, what are the general side effects or complications from the surgery that one may expect?
With any surgery, there are always going to be some risks. Just like with any surgery, this is the risk of bleeding, risk of infection. But the biggest thing that I usually worry about, probably one of the worst complications, would be pneumonia. And this is something we discuss with patients kind of before what to do to avoid it. One of them is stopping smoking. And some of the more common complications are usually pretty well tolerated. It has to do with just how healthy your lung is. The lungs that are healthier will heal faster, and lungs that had more effect from emphysema and COPD will take longer to heal. So as we had to do some of the dissection throughout the lung tissue, some of these areas will need additional time to heal. So we call it prolonged air leak. Sometimes it's just the surface needs not just 1 or 2 days to heal, but it may take a week or 2 weeks. But some of these specific details we discuss as I counsel patients who come in for evaluation before surgery.
Okay, fantastic. Thank you so much, Dr. K, for sharing this information. Very helpful. Anybody have any other questions or?
Dr. Patibandla, there's a question in the chat. Would you like me to read that?
Yes, please.
It says, I am a lung cancer survivor, lobectomy 2 years ago, non-small cell, stage 1, no chemo. I quit smoking 34 years ago. I am 67 years old. My question is, what can I do to strengthen my lung capacity since my surgery? And also, what do you recommend for the nerve pain in my ribs and muscle spasms across my abdomen? I have self-care questions. Appreciate any information. And can I also ask Dr. Kotova if you answer any further questions, can you speak up just a bit?
Yes,
Thank you.
And I can add this. So after surgery, unfortunately, the lung does not grow back after surgery. However, you can do some things which will help you to kind of recruit the capacity. And majority of this focuses around kind of working on your endurance. So basically, as you establish your exercise routine, this will recondition your lung and also your heart as well to function better. So with those, that's what I would suggest you do. And some of these routines are not necessarily very difficult. In terms of some of this post-surgical pain, there are a couple of things that we can do, and perhaps some of this can be better addressed if you'd like to just maybe, Deborah, you can provide the office contact so I can give more information about pain control, just because that'll be more specific to that person who had the question.
Sure, happy to do that.
Fantastic, thank you. And I think there is one other question about smoking. Certainly, cigarette smoking. The question is, how are other forms of smoking associated with lung cancer, such as marijuana? Cigarette smoking is associated with higher risk for lung cancer, but any form of smoking is not good for lung health and also associated with lung cancer. Marijuana, it's in the early phases. We don't have solid data to say how strongly it is associated with lung cancer, but we do know that any form of inhaling smoke into your lungs is not good for your lung health. Any additional thoughts from anyone on the panel on that question?
I just want to reinforce one of the things that you just mentioned, that we do not have good data. It took decades until we had enough data to demonstrate that the cigarette smoking was related to lung cancer. There was some data that took maybe 20, 30 years, but it was not until maybe like 50 years of data collection and analysis, which actually convinced people to believe this. So, and as you can imagine with marijuana smoking, it only became legal a couple of years ago. So there is going to be a long time before we actually demonstrate that there is likely a link. Right now, some of the earlier smaller studies that show that potentially does have not as much of an effect, but it does have much smaller but positive effect that relates to lung cancer. But it's also other diseases of the lung that are related to not so much that, but to inhalation of like a heat and hot air, which damages the lungs.
Yeah, in line with that, I also wanted to say that we don't support vaping because vaping can cause also other side effects on the lungs. It causes inflammatory diseases of the lungs. We have had some cases requiring lung transplant after vaping, especially the vape in which marijuana was used. There was a case report of that. So we don't have enough data on vaping and lung cancer, but that's still not there yet. But it's still unsafe when we don't support it.
Very good point, Dr. Dadla. Thank you, Dr. K. In the interest of time, I would like to move forward with asking a few questions to Dr. Dhami. Dr. Dhami is a radiation oncologist and also the chief of oncology at PeaceHealth. Thank you, Dr. Dhami, for joining today.
Thank you for having me.
My first question to you is, when is radiation therapy indicated for lung cancer patients?
Good question. Radiation has a potential role in all stages of lung cancer. It can be given with definitive intent, where we're aiming for a cure. It can also be used for palliative intent, when we're focusing on alleviating or reducing symptoms related to the cancer, such as pain, bleeding, and difficulties breathing. And then in early stage lung cancer, radiation therapy is used for patients who are not candidates for surgery or who refuse surgery altogether. Particularly for early stage lung cancer, radiation therapy is delivered using stereotactic body radiotherapy over up to 5 treatments. This is commonly known as SBRT or SABR. This form of treatment delivers a high dose intensity to the tumor while minimizing dose to the surrounding structures. If SBRT is not feasible, then we will consider treatment over a longer course, potentially 5 to 15 treatments for early stage lung cancer. Now, for locally advanced lung cancer, it could be a combination of treatments, trimodality, surgery, radiation, chemo. It may be surgery and chemo. It could be a combination. What we do know is for those patients who are not candidates for surgery, the standard of care is combination of radiation therapy and chemotherapy for approximately 6 weeks, followed by immunotherapy, which Dr. Dadla will elaborate further upon. One area that's an evolving area is oligometastatic disease, which is stage 4 lung cancer, but there's limited metastasis, meaning there's limited disease outside of the lung. And in these cases, definitive treatment where we're treating the local site as well as the limited areas of spread may improve outcomes. The most important aspect is that we need to review these patients in a multidisciplinary fashion. At PeaceHealth, we have a dedicated thoracic tumor board conference in which all specialties, thoracic, surgery, pulmonology, radiology, radiation oncology, medical oncology, pathology, we all review these patients' cases for comprehensive oncology recommendations.
Fantastic. Great points, Dr. Dhami. I think a few takeaways from that excellent information is that in certain lung cancer stages, it's not just one treatment, it's a multimodal treatment. It's surgery, chemo, radiation to provide the personalized and the most effective treatment for that particular patient. And I echo your points about the multidisciplinary sessions. And it's a great value for the patient care. And every time that we have a session, there's not even a single session that goes by wherein I'm like, okay, that's an added thing that we provided to this patient because we discussed the case there.
And also a plug for PeaceHealth is we are the only site in Vancouver to have a dedicated thoracic tumor board, not just a general tumor board, but a thoracic tumor board.
Yeah, a great conference. And one other point that I wanted to ask Dr. Dhami, as you were saying, in some cases, you mentioned that SBRT is not feasible. What are the other, forms of radiation therapy that can be offered?
Yeah, so it mainly, so we consider several factors when considering radiation treatment. One is the intent. Are we going for a cure, or is this palliative treatment? Dose is going to be higher when it's going to be more definitive rather than palliative where the dosages are lower. Location is very important, especially for stereotactic body radiotherapy. So central tumors are tumors within 2 centimeters from the proximal bronchial tree. Ultracentral is when it's abutting that proximal bronchial tree or abutting critical structures like the vasculature, the heart, the esophagus. We know for these cases, we have to deliver radiation over 5 or more treatments to reduce risk of side effects. And then for locally advanced lung cancer, the radiation treatment is given over 6 weeks. So it's lower dose per day, but the total definitive dose is over those 6 weeks.
I see. So if the location of the cancer is closer to the major critical structures, you do the lower radiation at more intervals to reduce the side effects.
Yes, it's fractionated further, correct.
Fantastic. Dr. Dhami, would you also share with us what are the usual complications with radiation?
Of course. So risk and side effects of radiation therapy are all about what we have to go through in order to target the tumor. So where's the tumor located and what's the critical structures nearby? For SBRT treatments, the vast majority of patients do very well. They have minimal long-term side effects. A common acute side effect during SBRT is that patients may have transient fatigue. It'll peak about a month after treatment. But over half of patients have no side effects whatsoever, acute side effects whatsoever during SBRT. With locally advanced lung cancer with radiation, side effects are gradual over those several weeks and gradually resolve once treatment's done. This can include fatigue, chest wall pain, localized skin rash, pain or discomfort with swallowing, shortness of breath, cough, rib fractures, inflammation of the lung. This all will depend on what we're treating and where that is in respect to other parts of your body. At your visit with your radiation oncologist, we go over all the potential side effects, short-term and long-term, in great detail.
Fantastic. That's excellent information, Dr. Dhami. Anyone have any other questions for Dr. Dhami?
I do want to talk more about the CyberKnife machine that we have, if that's
yes.
Okay.
I was just thinking about it. Yeah, could you please tell us about the CyberKnife?
So the CyberKnife system is a radiation treatment machine that delivers stereotactic body radiotherapy. That's a radiation where it's high dose to a small target over up to 5 treatments. There are many benefits of CyberKnife using that machine for delivering this type of radiation. First, it's a robotic system, which means that we can have real-time tracking of the tumor for precise and accurate treatment delivery. With frequent imaging of the machine can adjust and move as the patient breathes. Because remember, when you're breathing, the tumor is moving as well, and the robot can account for that motion, which allows us to reduce the dose to the critical structures around you. Secondly, it doesn't require an invasive frame for immobilization of the body, so patients are quite comfortable on the machine. And lastly, there's no post-treatment recovery period. So if patients need additional treatment after radiation, they can continue on if indicated. Of note, we're the only site, PeaceHealth is the only site in the Portland metro region to offer the CyberKnife robotic system.
That sounds fantastic. The name sounds a little scary, but I think the advantages with that are very significant and seems to be very beneficial for the patients. Thank you, Dr. Dhami. Next, I would like to invite Dr. Dadla and take this opportunity to ask him a few questions. Dr. Dadla is our medical oncologist, and he has extensive knowledge on lung cancer, and he keeps himself up to date with all the changing guidelines. He's my go-to guy whenever I have a question about the medical oncology field. So wonderful to have you, Dr. Dadla. So we know, things have changed tremendously over the last decade, right, in how we manage the lung cancer patients. I think especially more when it comes to the medical oncology field. Now we have multiple targeted therapies, immunotherapy, in addition to chemotherapy. So could you please talk to us about what is targeted therapy and how is it offered to the patients and to whom it is offered?
Thanks for having me here, Dr. Patibandla, and thanks for helping arrange this wonderful webinar. In order to better answer this question, I would like to go back to the very basic question of what is cancer. Cancer is basically uncontrolled growth of cells, and the uncontrolled growth can occur either due to genetic mutations or because the immune system does not recognize this growth. And so there are three basic types of treatment. We have chemotherapy, which is your traditional anti-cancer drugs. They work by killing fast-growing cancer cells, but in the bargain, they also end up killing other fast-growing cells that belong to the body. Like if they kill fast-growing hair cells, it results in hair loss. If it kills fast-growing gut cells, it results in nausea and diarrhea. So that's how the side effects occur. The second set of treatments is called immunotherapy, which work by unleashing the body's immune system against the cancer. But you can have side effects when you unleash the body's immune system against the body's organs itself. Like if it unleashes the immune system against the skin, it can cause a skin rash, or if it unleashes the immune system against the gut, it can cause diarrhea. But immunotherapy is way better tolerated compared to chemotherapy. The side effects are way less. And for most people, it's like taking a bag of saline every few weeks. So it's very well tolerated. The third type of treatment is what we call targeted therapy, also known as personalized treatment or personalized medicine, and also known as precision medicine, in which we study the patient's genetic mutations, the genetic mutations that the tumor has, and then we specifically target those genetic mutations. And the side effects of those drugs, they're very specific to those drugs and they depend upon the individual drug. So that's the overview of anti-cancer treatment. But we're slowly moving away from chemotherapy and more towards personalized therapy that is customized to the genetic mutations of each tumor.
That's fantastic information. So how do we know who would benefit from targeted therapy, Dr. Dadla? How do we identify those patients? Is it for everybody or?
So what we do nowadays in cancer medicine is, each and every tumor that we remove, we test it for genetic mutations, and we see what mutations the tumor has, and then we make a determination as to what therapy would best fit that patient. And in terms of deciding on who needs treatment, we don't treat all patients. The patients who have tumors less than 3 centimeters, very early stage, which is also known as stage 1A, non-small cell lung cancer, these patients don't need any kind of treatments from us, and they can be watched, by the surgery team after their surgery is done. But anything larger than 3 centimeters and all small cell lung cancers, they do need some sort of systemic therapy, because we think of lung cancer like a poppy plant. So even if you remove the poppy plant with surgery, you want to make sure that there are no poppy seeds that have escaped. So you use systemic therapy to wipe the body clean of any cancer that has escaped. So small lung cancers less than 3 centimeters, no other treatment. But if it's larger, yes, that would require some sort of treatment to prevent recurrence of cancer.
Fantastic. I love that analogy. I hear that all the time, but every time you say it, it's a great analogy.
Poppy plants have become famous. Yes.
So you test for the mutations, Dr. Dadla, if people have mutations and you target the mutations. Wonderful. And I read the statistics recently about the molecular testing. Please correct if I'm missing anything. I understand that about 1 in 3 lung cancer patients, non-small cell lung cancer patients, have this targeted mutations, but we are missing more than 50%, almost 2 in 3 potentially eligible patients are not being tested for this mutation.
Yes, I would say that is correct. As you get into the smaller community setting, I would say some of the older oncologists, they don't test for these mutations. But now, it is becoming more widespread where almost everybody is getting tested for these mutations. I would say right now, each and every person who has lung cancer should be tested for these mutations, not only just for, whether they need treatment at this time, but also it could help plan their future treatments. More important than that, the data on these genetic mutations and what treatments work best for them is improving very rapidly. And so we have many newer treatments which are developing. So as that pool of data develops, I think the treatment of lung cancer will continue to improve.
Fantastic, great point. So it's when someone is diagnosed with lung cancer, things to ask your doctors: what's the type of lung cancer? What's the stage of lung cancer? And with all the points that the doctor has mentioned, it's also important to know if you have any targetable mutations. So it's becoming more and more personalized medicine. And as you may have noticed with all the discussions that have happened over the last half an hour or so, it's a multidisciplinary approach. I think that makes a big difference. And I think that's what we strive for at PeaceHealth. Anybody have any other questions for Dr. Dadla? Great information, Dr. Dadla.
Don't have any additional questions in the chat at this time.
Okay, fantastic. So thank you so much, everyone, for taking the time to join the session today. And I hope this was helpful to you all. If I may summarize everything that's been discussed over the last 45 minutes or so, a few take-home points I would say is anybody can get lung cancer. It's often considered as like a smoker's disease, but more than 20% of lung cancers are diagnosed in someone who have never touched a cigarette. So anybody can get lung cancer. But if you smoke, you're at higher risk of having lung cancer. And quitting cigarette smoking is one of the best things that you can do to improve not just the lung health, but your health across the board. And quitting cigarettes, can definitely be challenging, especially if you have been smoking for years, because it is a form of addiction. So please seek help. Now there are multiple FDA-approved medications and proven behavioral techniques to help you quit smoking. And as you have seen here, the lung cancer management is rapidly growing, and the options are improving, and it can be cured if it is diagnosed at early stages. So screening plays a significant role in early diagnosis. So if you're between the ages of 50 and 80, and if you have smoked cigarettes, please discuss with your primary care doctor or anyone in your healthcare team to see if you qualify for lung cancer screening. And thank you all again for taking the time to join and tuning in. I hope you all have a good rest of the evening.
Thank you, everyone.
Thank you.